Think about the doors in your life, your front door, maybe your car door. They control flow, right? Access.
Uh-huh. Simple function, but essential.
Exactly. Now, picture tiny, incredibly vital doors inside your heart. These are your heart valves, and they're absolutely key for keeping blood moving, in the right direction.
One-way streets, basically.
Precisely. And if you're tuning in because you want to get a solid grip on complex clinical topics, especially the ones crucial for your practice, maybe for exams, well, you're in the right place.
It's amazing how fundamental these valves are. When they malfunction, the ripple effect through the whole cardiovascular system is just huge.
It really is. Which brings us to our deep dive today. Valvular heart disease, or VHD.
VHD.
We're working from a great source, the Valvular Heart Disease Nursing Guide. And our mission really is to pull out the most critical info, the stuff you absolutely need for clinical work for those nursing exams.
Think of it as your focused briefing on VHD. We're hitting the high points, the testable stuff, the clinically relevant bits.
Okay, let's unpack this. The guide starts by saying there are two main ways these valves go wrong: stenosis and regurgitation.
Right. Stenosis first.
Stenosis is like, imagine a door that's rusted shut almost. It just won't open all the way.
Stiff. Narrowed.
Yeah, narrowed. So blood flow gets obstructed, it's harder to push through.
And that creates pressure behind the valve, right? The chamber before it has to work way harder. We call that pressure overload.
Pressure overload, got it. Then there's regurgitation.
It's a leaky valve.
Exactly, the leaky valve, like a door that doesn't seal properly. So blood leaks backward when it shouldn't, sometimes called insufficiency.
And that backward leak means the heart's pumping the same blood more than once. It's inefficient. That leads to volume overload in the chambers.
Volume overload for regurgitation, pressure overload for stenosis. Okay.
Two key concepts right there.
The guide also mentions a couple of less common issues, just for completeness. Prolapse. Mainly the mitral valve.
Yeah, mitral valve prolapse, or MVP. The leaflets get kind of floppy, bulge back into the atrium.
And then atresia. Sounds serious.
It is. It's congenital, meaning present at birth. The valve just doesn't form a proper opening at all, often the pulmonary valve.
Okay, so good to know about, but stenosis and regurgitation are the main players we'll focus on.
Definitely the most common ones you'll encounter and likely see on exams.
So why is this VHD knowledge so vital for nurses? Well, the guide is clear. Untreated VHD really impacts patients' lives. We're talking serious symptoms, major complications.
Like heart failure, which is a big one.
Huge. And arrhythmias, those dangerous heart rhythms, stroke, pulmonary hypertension, even sudden cardiac arrest.
These aren't minor issues. They underline why early detection and proper management, where nurses play a huge role, are so critical.
Absolutely. And the guide paints this interesting global picture. It's almost like VHD is two different diseases depending on where you live.
That's a really important point for understanding the different causes, the etiology.
So in developed countries like the US or UK, the guide says VHD is mostly age-related, degenerative.
Wear and tear, essentially. Although, as we'll see, it's a bit more complex than that.
Right, but things like calcific aortic stenosis, that rusted aortic valve, and degenerative mitral regurgitation, the leaky mitral valve get much more common as people get older, especially over 75.
And with populations aging, that means nurses are seeing more and more of this. You need to be sharp at assessing older adults.
But then you shift focus to developing countries. Completely a different story. The guide points to rheumatic heart disease, RHD, as the main culprit.
And it hits young people, kids, young adults under 25, mostly.
It's linked directly to untreated strep throat infections, and sadly, poverty plays a huge role.
Yeah, it's a disease of poverty, largely preventable with access to basic healthcare, like antibiotics for strep. And what's really worrying, the guide notes that the global prevalence of RHD has actually increased since 1990.
Increased. Wow. That highlights major global health disparities.
It really does. And even in Western countries, while it's less common now, the guide reminds us nurses might still see RHD.
Right? Maybe in immigrant populations or older adults who got it years ago, or even sometimes in marginalized groups within wealthier nations.
So that patient history is key. You can't assume it's always degenerative, especially depending on the patient's background.
Okay, let's zoom back in on the developed world specifics, because this is prime exam territory. Aortic stenosis, AS. The guide calls it the most common cause of left ventricular outflow obstruction.
Basically, trouble getting blood out of the main pumping chamber.
And the numbers jump with age. About 12.4% of folks over 75 have it.
And the cause? Usually calcification. Stiffening of the valve leaflets. This can happen to a normal 3-leaflet valve.
Or, and this is important, a bicuspid valve.
Exactly. That's a common congenital thing.
Yeah.
Maybe 1% of people are born with 2 leaflets instead of 3. And those bicuspid valves tend to get stenotic, stiffen up much earlier in life.
So if a younger patient has AS, you might suspect a bicuspid valve. Good clinical point.
Definitely. A key piece of history.
All right, what about aortic regurgitation, AR, the leaky aortic valve?
Prevalence also climbs with age. Moderate to severe AR in about 13% of people aged 55 to 86, according to the guide.
And the causes. It could be the aorta itself widening, stretching the valve opening, or problems with the leaflets.
And interestingly, the guide highlights infective endocarditis, infection of the valve, as a growing cause, maybe up to 25% of surgical AR cases.
Wow, endocarditis. That links back to prevention, doesn't it? Assessing risk, patient education.
Absolutely. Especially for patients with known valve issues already.
Okay, mitral valve. Mitral stenosis, MS.
Narrowing of the mitral valve between the left atrium and left ventricle.
In developed countries, the guide says this is almost always due to previous rheumatic heart disease.
Yeah, RHD is the big one for MS.
It's less common overall in the U.S., maybe 0.1% prevalence. But here's a crucial point the guide makes. MS is the most common VHD seen during pregnancy.
That's a huge takeaway for anyone working in OB/GYN or with pregnant patients. The body's changes during pregnancy can really unmask or worsen MS. Needs careful watching.
Definitely one to remember. Now, mitral regurgitation, MR, the leaky mitral valve.
This one's super common. The guide says it's the most frequent moderate to severe VHD found out in the community in developed countries.
And again, strongly linked to aging, over 9% prevalence in those over 75.
Main causes listed are mitral valve prolapse, a floppy valve condition, often from something called mixed meniscus degeneration.
Fancy term for weakened valve tissue.
Pretty much. And the other big cause is ischemic heart disease. Damage to the heart muscle itself, maybe after a heart attack, can mess up how the valve closes. That's called secondary MR.
Primary MR is the valve itself. Secondary MR is due to heart muscle problems. Good distinction.
Crucial distinction, actually, because it affects treatment choices. The guy also notes that MVP itself is pretty common, affecting 2–3% of people.
Okay, and briefly, tricuspid regurgitation, TR.
Leaky tricuspid valve on the right side. Usually the guide says severe TR is secondary. It happens because the right ventricle gets dilated, often from left-sided heart failure or high pressures in the lungs, pulmonary hypertension.
So fixing TR often means fixing the underlying left-sided problem.
Exactly. Address the root cause.
Now, risk factors. The guide lists a bunch, really important for your assessments and patient teaching. Aging, obviously, for the degenerative stuff.
But also hypertension, high cholesterol, diabetes, smoking.
Gender for AS specifically. Congenital things like that, bicuspid aortic valve.
History is huge, rheumatic fever, infective endocarditis.
Also certain connective tissue or autoimmune diseases, chest radiation history, obesity, even some meds, poor diet, lack of exercise. It's a wide net.
Which just emphasizes how important a thorough history and focusing on those modifiable risk factors is. Lifestyle matters.
So circling back, why do you need to be a VHD expert? Because, as the guide stresses, these conditions have a massive impact. Debilitating symptoms, serious complications.
Complications that nurses are often the first to spot signs of.
Right. And the nurse's role is central. From that initial assessment, hearing a new murmur, maybe, to ongoing monitoring, giving meds safely, especially tricky ones like anticoagulants.
And patient education. That's massive. Public awareness of VHD is often low, the guide says. So explaining things clearly to patients and families is key.
Empowering them with knowledge. Okay, let's shift gears. Let's talk how VHD messes with the heart's function, the pathophysiology.
The guide uses a nice analogy here. Normal valve function is like a perfectly timed symphony.
I like that. Everything opening and closing just right.
Precisely. But VHD disrupts that symphony.
So for stenosis, the obstructed door, the guide explains that narrowing creates pressure overload in the chamber before the valve. The heart has to push harder.
And it introduces the term pressure gradient, the pressure difference across that narrowed valve. Higher gradient generally means worse stenosis. That's a key measurement, often on echo reports.
Good to know. And the heart muscle responds to this pressure by thickening.
Yep, concentric hypertrophy. The muscle bulks up to generate more force, like a bodybuilder lifting heavy weights.
Okay. Then for regurgitation, the leaky door, the backward flow causes volume overload.
Right, the chambers involved have to handle extra blood volume sloshing back and forth.
And the heart's response here is different.
It enlarges or dilates and undergoes eccentric hypertrophy. The chamber gets bigger and the walls thicken, but in a different way to accommodate that extra volume.
Understanding those two core responses, pressure overload causing concentric hypertrophy and stenosis, and volume overload causing eccentric hypertrophy and dilation in regurgitation, that seems fundamental.
Absolutely fundamental. It explains so much about the downstream consequences and the symptoms patients experience. Definitely nail those concepts for exams.
And the guide links these directly to symptoms. For left-sided issues, that pressure backup causes pulmonary congestion, leading to...
Dyspnea, shortness of breath, especially with exertion initially.
Makes sense. And if not enough blood is getting pumped forward, either because of stenosis or regurgitation,
Fatigue, weakness, the body's just not getting enough fuel.
chest pain, angina can happen in stenosis.
Yeah, that thickened, overworked heart muscle needs more oxygen, especially during exertion. Can also happen in severe regurgitation sometimes.
And if the brain isn't getting enough blood flow,
Dizziness, lightheadedness, maybe even syncope passing out, particularly dangerous in aortic stenosis.
so connecting the hemodynamics to the symptoms is key for assessment and patient education, explaining why they feel short of breath, for instance.
Exactly. It helps you anticipate problems and explain the rationale for care.
Okay, let's get more specific. Hemodynamics of each major lesion, focusing on those exam-relevant points from the guide. Aortic stenosis, AS.
Narrowed aortic valve. Obstructs flow from the left ventricle, LV, to the aorta during systole, when the heart pumps.
Creates that high systolic pressure gradient across the valve. LV responds with concentric hypertrophy.
And the guide gives a key number. Normal aortic valve area is 3 to 4 centimeters. Symptoms usually kick in below 1.0 centimeter out. Remember that threshold for severe AS.
Below 1.0 centimeter for severe AS symptoms. Got it. And if it progresses?
The pressure inside the LV can rise even during diastole, when it's supposed to be relaxing and filling. That pressure backs up
Backs up where?
into the left atrium, then the pulmonary veins, causing pulmonary congestion, pulmonary hypertension, and eventually straining the right side of the heart, leading to right heart failure. It's a cascade.
A domino effect. Okay. Aortic regurgitation, AR, leaky aortic valve.
Blood flows backward from the aorta into the LV during diastole, causes LV volume overload.
And the LV response?
Eccentric hypertrophy and dilation. It gets bigger to hold the extra volume.
The guide mentions this leads to a large stroke volume and often a widened pulse pressure.
Right. High systolic pressure, low diastolic pressure. That's a classic physical exam clue for AR. Worth noting.
So initially the heart compensates, but eventually?
Chronic volume overload leads to increased pressure in the LV at the end of diastole. That backs up into the lungs, causing pulmonary congestion, heart failure symptom.
And the guide flags acute AR as different, like from an aortic dissection.
Yeah, that's a medical emergency. Sudden, massive volume overload. The LV has no time to adapt. Leads to rapid pressure equalization, severe pulmonary edema, flash, pulmonary edema, and shock. Very dangerous.
Okay. Mitral stenosis, MS narrowed mitral valve.
Obstructs flow from the left atrium LA to the LV during diastole.
Creates a diastolic pressure gradient across the valve. The LA enlarges.
And the big problem, according to the guide, that pressure backs up directly into the pulmonary veins, pulmonary venous congestion. That's why dyspnea is such a hallmark symptom.
And over time, that leads to pulmonary arterial hypertension.
Yep, first passive, then it can become reactive and more severe. Puts a huge strain on the right ventricle, leading to RV hypertrophy, dilation, and right heart failure.
The guide also mentions a high risk of atrial fibrillation, AFib in MS.
Definitely. The LA gets stretched and irritated, and losing that coordinated atrial contraction, the atrial kick, really hurts LV filling when the valve is already narrow. AFib is bad news in MS.
Got it. Mitral regurgitation, Mr. Leaky mitral valve.
Blood flows backward from the LV into the LA during systole. Volume overload affects both the LA and the LV.
So both chambers enlarge. LV gets dilation and eccentric hypertrophy again.
Correct. And the guide explains an interesting point. The total amount of blood the LV pumps might increase, but the effective forward flow to the body is actually reduced because so much is leaking backward.
Makes sense. And chronic MR eventually leads to
LV dysfunction, pulmonary congestion, pulmonary hypertension, and also a high risk of AFib.
similar endpoint issues. And acute MR. Like if a papillary muscle ruptures after an MI.
Similar to acute AR, sudden, severe backup into the LA. High LA pressure causes acute pulmonary edema and often cardiogenic shock. Another emergency.
Okay. And tracted regurgitation, TR, as we said, usually secondary, causing systemic congestion signs like edema.
Right. Understanding these specific hemodynamic consequences for each valve is crucial. It's the foundation for everything else.
All right, let's go even deeper. The guide discusses the specific pathophysiology of key VHD types. This gets into the nitty-gritty biology, but it's clinically relevant. Degenerative calcific aortic stenosis first.
And the big message here from the guide, it's not just passive wear and tear. It's an active biological process.
Yeah.
Very similar in some ways to atherosclerosis.
Active, not passive. Okay, so what's happened?
It starts with some injury to the valve's lining, the
Yeah.
endothelium. That allows lipids, like oxidized LDL cholesterol, to get into the valve tissue.
Like an artery plaque buildup.
Exactly. That triggers inflammation, macrophages, cytokines. The whole inflammatory cascade gets involved.
And then the guide mentions something about valvular interstitial cells, VICs.
Yes, this is fascinating. These normally quiet cells get activated by the inflammation and lipids, and they transform into cells that act like bone-forming cells, osteoblasts.
They turn into bone cells in the heart valve.
Effectively, yes.
Yeah.
These osteoblasts-like VICs then start actively laying down calcium crystals, hydroxyapatite, within the valve leaflets. That's what makes the valve stiff and calcified.
Wow. So it's active bone formation.
Active calcification. The guide mentions specific signaling pathways involved, things you might see in research papers like Ranko-Ranko PG, BMPs, WANT pathway, Notch. These regulate that cell transformation and bone formation.
And it mentions matrix glyprotein. Needs vitamin K.
Right, MGP helps inhibit calcification, and it needs vitamin K to work properly. So there's ongoing research into whether vitamin K status plays a role in AS progression. Still early days, though.
So this active process explains why atherosclerosis risk factors are relevant.
But also why statins, which target cholesterol, haven't really worked to stop AS from getting worse. They don't hit that bone formation pathway directly.
Okay, that makes sense now. What about rheumatic heart disease, RHD?
The guide stresses this is an immune system problem triggered by group A strep, the strep throat bacteria.
How does strep throat lead to heart valve damage?
It's called molecular mimicry. The antibodies your body makes to fight the strep bacteria accidentally recognize similar-looking proteins on your heart valves.
Mistaken identity.
Exactly. A type 2 hypersensitivity reaction. This cross-reaction causes inflammation in the heart carditis during the initial illness, which is acute rheumatic fever, ARF. You might see specific microscopic changes called Aschoff bodies in the heart tissue.
And chronic RHD develops later.
Yes, usually after repeated episodes of ARF. The chronic inflammation causes scarring and thickening of the valve leaflets, fusion of the edges where they meet, commissural fusion, and shortening of the little cords that support them, chordae tendineae.
Which valve is most affected?
Mitral valve most commonly, then the aortic. This damage leads to either stenosis, regurgitation, or both.
So the key message from the guide regarding RHD is prevention.
Absolutely. Treat strep throat fully with antibiotics to prevent ARF in the first place. And for those who've had ARF, long-term penicillin prophylaxis is crucial to prevent recurrences and stop the progression to chronic RHD. Huge nursing education point.
Okay. Infective endocarditis, i.e. infection of the heart lining, usually the valves.
Requires a perfect storm, usually. First, some damage to the endocardium, the inner lining.
What causes the initial damage?
Could be turbulent blood flow from existing VHD, prosthetic valves, catheters, IV drug use, lots of things. This damage allows tiny clots of platelets and fibrin to form that's non-bacterial thrombotic endocarditis, or MBTE.
Like a rough patch for bacteria to stick to.
Exactly. Then you need bacteria or fungi to get into the bloodstream, bacteremia or fungemia. Common culprits are Staph aureus, Strep viridans, Enterococcus.
And these microbes find that NDTE.
They adhere, colonize it, and form biofilms, slimy protective layers. They multiply and create these infected masses called vegetations.
And those vegetations cause problems.
Big problems. They can destroy the valve tissue locally, causing holes, abscesses, tearing leaflets. If the infection spreads to the heart's electrical system, it can cause heart block.
And bits can break off.
Yep, embolize. Travel through the blood. Left-sided vegetations can cause strokes or block arteries elsewhere. Right-sided ones go to the lungs, causing pulmonary emboli. The guide also mentions immune responses causing things like Osler's nodes or Roth spots.
Okay, that's a lot of detail on the specific processes. Now, how does the heart try to cope with VHD, the compensatory mechanisms?
The guide mentions a few. The Frank-Starling mechanism helps initially in regurgitation. The more the ventricle stretches with extra volume, the harder it contracts, up to a point.
Like a rubber band.
Sort of. Then there's neurohormonal activation, the RAAS system, the sympathetic nervous system. They kick in to maintain blood pressure.
Helpful at first.
Yes, but chronically they're bad news. Cause fluid retention, Vasoconstriction, more strain on the heart, contribute to remodeling.
And remodeling itself, the hypertrophy we talked about, concentric for stenosis, eccentric for regurgitation.
Right. Initially compensatory helps maintain output,
Right.
but over time, that remodeling becomes maladaptive. The heart muscle changes structure, becomes less efficient, stiffer, fibrosis can develop.
And eventually, compensation fails.
That's when you get heart failure. The heart just can't keep up anymore. VHD is a major cause of both systolic failure, weak pump, and diastolic failure, stiff pump, can't fill properly. Recognizing that transition to heart failure is critical for nurses.
Okay. The guide then organizes VHD valve by valve aortic, mitral, tricuspid, pulmonic, outlining the stenosis regurgitation for each, causes, consequences. A good way to structure your thinking.
Very logical. Let's consolidate the information.
It makes sure to mention mitral valve prolapse, MVP, again, common, often benign, but a key cause of mitral empark. Remember that mid-systolic click sound?
Definitely. And while many with MVP are fine, it is a risk factor for significant MR and needs monitoring.
The guide also mentions mixed valve disease, more than one valve involved, or one valve with both stenosis and regurgitation.
Those cases can be tricky. You have to figure out which lesion is hemodynamically dominant driving the problems.
And prosthetic valve dysfunction. Even artificial valves aren't perfect.
Right. Bioprosthetic valves, tissue valves, can wear out over time, structural valve deterioration, SVD. Mechanical valves can get clots, thrombosis, or tissue overgrowth, pandanus. Both types can leak around the edges, paravalvular leak, PVL, or get infected, prosthetic valve endocarditis, PVE.
So post-valve replacement care involves watching for these specific issues.
Absolutely. Long-term surveillance is key.
Now, this next bit is super important clinically and for exams. The AHA-ACC Valvular Heart Disease Staging System, stages A, B, C, and D.
A standardized way to classify VHD severity and progression, guiding management. Every nurse dealing with cardiac patients should know this.
Stage A, at risk. You have risk factors, like a bicuspid valve, history of RHD, but no actual valve problem yet. Focus is prevention.
Makes sense. Primary prevention for those identified as high risk.
Stage B, progressive VHD. There is mild or moderate valve disease seen on echo, maybe a murmur, but crucially the patient is asymptomatic, no symptoms.
Management here is usually surveillance, watchful waiting with regular checkups and echoes to see if it worsens.
Stage C, asymptomatic severe VHD. This is key. The valve disease is severe based on echo criteria, but the patient still feels fine, no symptoms.
And stage C is split into C1 and C2.
Right. C1, severe VHD, no symptoms. A and D, the left ventricle, is still coping well, compensated.
C2, severe VHD, no symptoms. BUT. There's evidence the LV is starting to struggle, decompensating, even if the patient doesn't feel it. Maybe the EF is dropping, or the ventricle is dilating significantly.
That C1 versus C2 distinction is critical, isn't it? Because C2 might push you towards intervention even without symptoms.
Exactly. The goal is to intervene before irreversible LV damage occurs. Stage C is where a lot of the complex decision-making happens, especially regarding timing of surgery or transcatheter procedures.
The guide stresses considering intervention in stage C, definitely C2, before symptoms hit hard.
Because waiting for symptoms often means you've waited too long and outcomes might be worse.
And finally, stage D, symptomatic severe VHD. Severe valve disease and the patient has symptoms caused by it.
Stage D generally means intervention is needed, the horse is out of the barn, so to speak. Time to fix the valve to relieve symptoms and improve prognosis.
The guide also notes that within B, C, and D, the severity, mild, moderate, severe, is based on specific echo numbers, valve areas, gradients, regurgitant volumes. We'll get to those numbers.
But understanding the ABCD framework, integrating valve severity, symptoms, and ventricular response is fundamental. Expect questions on this.
Okay, clinical manifestations. What does VHD look like? As we said, the guide emphasizes it can be silent for a long time. Stages A, B, even C.
Which is why routine physical exams, including careful listening with a stethoscope, are so important. You might pick up a murmur before the patient feels anything.
And when symptoms do start, they can be subtle, maybe blamed on just getting older.
Very common. Oh, I'm just slowing down. Plus, the guide notes low public awareness. People might not connect shortness of breath with a heart valve problem.
So nurses play a big role in educating patients about what symptoms could be related to VHD and warrant checking out.
Definitely. Asking the right questions during history taking.
But when symptoms become obvious, usually in stage D, they stem from that hemodynamic overload. The guide lists the big ones: dyspnea, shortness of breath.
Exertional first, Then maybe orthopnea, can't breathe lying flat, or PND, waking up gasping at night.
Ah.
Classic signs of pulmonary congestion.
Fatigue, weakness from reduced cardiac output.
Makes sense. Not enough oxygenated blood getting around.
Chest pain or angina, classic in AS due to LVH and ischemia, but possible in severe ARMR too, and that critical point. Exertional syncope in AS is a really bad sign.
Red flag. Means the heart can't keep up output during exertion. Needs urgent attention.
Palpitations, feeling the heart race or skip beats, often due to arrhythmias like AFib, common in mitral disease especially.
Dizziness, syncope from low brain perfusion. Again, AS is a big culprit, but arrhythmias can cause it too.
Edema, swelling in the legs, ankles, maybe abdomen, ascites from right heart failure, systemic backup. Rapid weight gain is a clue too.
Fluid retention, yeah.
Other things the guide mentions: cough, maybe even hemoptysis, coughing blood, in severe MS, nausea, abdominal pain from liver congestion, decreased alertness in really severe low output states.
And don't forget acute presentations. Sudden severe dyspnea flash, pulmonary edema, acute chest pain, low blood pressure, shock. Think acute AR or min-R. And if there's fever, suspect endocarditis.
These acute scenarios need quick recognition and action. Okay, the physical exam. The guide says this is often where the first suspicion arises.
Absolutely. Your hands, eyes, and ears are powerful tools.
Vital signs clues. Wide pulse pressure in AR, high systolic, low diastolic.
Yep. Narrow pulse pressure in severe AS or low output states.
Also possible. And obviously heart rate and rhythm, tachycardia, bradycardia, irregularity suggesting AFib.
Inspection. Look for JVD, jugular venous distension points to high right-sided pressures. Check for edema, skin changes of poor perfusion.
Palpation, feeling the pulse, that weak, delayed parvus tardis's pulse in AS.
Classic. Or the bounding water hammer pulse in AR. Also classic. Feel the PMI, is it displaced, enlarged, hyperdynamic? Feel for thrills, palpable murmurs, or heaves lifts from hypertrophy. Maybe an enlarged pulsating liver and trite heart failure.
But auscultation listening is really the star of the VHD physical exam.
It truly is. The guide stresses being systematic. Listen over all 4 valve areas, aortic, pulmonic, tricuspid, mitral, with both the diaphragm for high-pitched sounds and the bell for low-pitched sounds.
Need to know your normal sounds first. S1, mitral tricuspid closure. S2, aortic pulmonic closure. How can they change?
S1 might be loud in MS day. The aortic part of S2A2 might be soft in severe AS. The pulmonic part, P2, might be loud if pulmonary hypertension is present. Note normal S2 splitting with breathing too.
Then the extra sounds, opening snap, OS, and MS.
High-pitched sound after S2. The timing tells you about severity. Earlier OS means worse MS.
Ejection clicks, mid-systolic click.
Ejection clicks can happen with stenotic aortic pulmonic valves or dilated great arteries. Mid-systolic click is the hallmark of MVP.
S3 gallop.
Low-pitched sound in early diastole usually means volume overload or systolic dysfunction. Think severe AR, MR, heart failure. Generally pathologic in adults.
S4 gallop.
Low-pitched sound in late diastole, just before S1, means decreased ventricular compliance, a stiff ventricle. Seen in AS, chronic hypertension, almost always pathologic.
Pericardial friction raw.
Cracky, grating sound indicates pericarditis, inflammation of the sac around the heart.
And then murmurs, the sound of turbulent flow. The guide gives a great framework for describing them, essential for communication.
Got to describe the timing. Systolic or diastolic. Early, mid, late, or holopan throughout. Remember, diastolic murmurs are almost always bad news.
Location, where is it loudest? Aortic area, pulmonic, tricuspid, mitral.
Radiation, where does the sound travel? To the neck?
AAS.
Axle.
Intensity. Grade 1 to 6 on the Levine scale. A is barely audible. Vise you can hear with the stethoscope off the chest, rare. Thrills usually start around grade 4.
Pitch, high, medium, low. Quality, harsh, blowing, rumbling, musical.
Shape. Crescendo gets louder, decrescendo gets softer, crescendo, decrescendo, diamond-shaped like AS, plateau, constant intensity like MR.
And finally, how it responds to maneuvers. This can really help differentiate murmurs.
Like breathing. Right-sided murmurs, TR, often get louder with inspiration Carvalho-Syme.
Valsalva or standing usually decrease preload, making most murmurs softer, except HOCM, hypertrophic cardiomyopathy, and the click murmur of early MVP, which get louder or appear sooner.
Squatting or leg raise increases preload, making most murmurs louder, but decreasing HOCM and delaying the MVP click murmur.
Hand grip increases afterload. Makes regurgitant murmurs, MRAR, VSD, louder, but makes AS and HOCM murmurs softer.
Wow, okay, those maneuvers are key diagnostic clues. The guide includes a classic murmurs cheat sheet table, too.
Invaluable. Lists the typical timing, location, radiation, quality for AS, AR, MS, MR, etc. Great for study and practice. And the bottom line, report any new or changing murmur immediately. It could signify worsening VHD.
That systematic description and reporting is crucial nursing practice. Okay, so history and physical raise suspicion. Now what? Diagnostic testing.
Right. We need objective evidence to confirm VHD, assess severity, check heart function, and guide treatment.
What are the main tools the guide mentions?
ECG, chest X-ray, echocardiography, the big one, stress testing, cardiac catheterization, sometimes advanced imaging like cardiac MRI or CT, and biomarkers like BNP.
Let's start with the ECG. What can it tell us about valves?
Not directly about the valves themselves, but it shows the consequences of VHD on the heart muscle and electrical system. Things like chamber enlargement, arrhythmias, ischemia.
So essential baseline info. The guide emphasizes systematic interpretation.
Always. Rate, rhythm, axis, intervals, PR, QRS, QT, P waves, QRS morphology, ST segments, T waves. Look for patterns.
What specific VHD-related findings does the guide highlight? Left ventricular hypertrophy, LVH.
Yeah, common in AS, chronic AR, hypertension. Look for voltage criteria like Suklo, Lyon, or Cornell, but importantly, also look for non-voltage signs like the strain pattern, ST depression, T-wave inversion, and lateral leads, left axis deviation, maybe signs of left atrial enlargement. Strain pattern is a key indicator of significant pressure overload.
Right, ventricular hypertrophy, RVH.
Seen with pulmonary hypertension, often secondary to left-sided VHD like MS, or severe MRAR or pulmonic stenosis. Look for right axis deviation, dominant R wave in V1, dominant S wave in V6, maybe RV strain pattern in right-sided leads, signs of right atrial enlargement.
Atrial enlargement, left LAE, or right RV.
LAE or P mitral, often seen in mitral valve disease, MSMR, or LV dysfunction. Look for wide notched P waves in lead 2, or a large negative component of the P wave in V1. RAE or P pulmonale, seen with lung disease or right-sided heart issues. Look for tall, peaked P waves in inferior leads, 2, 3 AVF, or V1.
And arrhythmias. Atrial fibrillation, AFib is a big one.
Very common, especially with LA enlargement in mitral disease, characterized by an irregular rhythm, no discernible P waves, just fibrillatory waves. Crucial to recognize because of the high stroke risk, especially in MS.
The guide likely has a table summarizing these ECG findings and criteria.
Yes, often presented that way for clarity. ECG provides valuable clues but doesn't clinch the VHD diagnosis itself.
Okay, the gold standard then? Echocardiography.
Absolutely. Ultrasound of the heart
Prostate.
provides detailed images of valve structure and function, chamber sizes, wall thickness, contractility, like ejection fraction, and uses Doppler to measure blood flow velocities and pressure gradients across valves and quantify regurgitation.
The guide discusses two main types, TTE and T.
Right. TTE is transthoracic echo. The probe is placed on the chest wall, non-invasive, readily available, usually the first step, gives a great overall picture.
But sometimes the images aren't clear enough.
Exactly. Obesity, lung disease can interfere. That's when T, transesophageal echo, comes in.
How does T work?
A small probe on an endoscope is passed down the esophagus, requires sedation. Because the esophagus sits right behind the heart, you get much clearer, high-resolution images, especially of posterior structures like the mitral valve and left atrium.
When is T typically used?
When TTE is inconclusive, if you strongly suspect infective endocarditis, better for seeing vegetations, evaluating prosthetic valves, getting fine detail of mitral valve anatomy for repair planning, checking for clots in the left atrial appendage before cardioversion, and often used intraoperatively during valve surgery.
So T gives better pictures but is invasive and has small risks.
Precisely. Trade-offs.
Now, the echo report, full of numbers. The guide probably details key parameters for grading severity.
Yes, and this is crucial exam material. There will likely be tables showing the criteria for grading stenosis and regurgitation severity, mild, moderate, severe.
For stenosis, say aortic stenosis, what numbers matter?
Key things are the peak velocity blood flow across the valve, the mean pressure gradient, and the calculated valve area, AVA. For severe AS, typically peak velocity 4 meters, mean gradient 40 mmHg, and AVA 1.0 centimeters. The guide might also mention index AVA, adjusted for body size, and criteria for very severe AS or tricky situations like low flow, low gradient AS.
And mitral stenosis.
Similar concepts, mean gradient across the mitral valve during diastole, calculated mitral valve area, MVA. Severe MS is often defined by MVA 1.5 centimeters or sometimes 1.0 centimeters, depending on source context, and a high mean gradient. Pressure half-time, PHT, is another measure used.
Okay, what about grading regurgitation? Seems more complex.
It is. Grading regurgitation involves integrating multiple parameters, both qualitative and quantitative. It's not just one number.
What kind of parameters for, say, aortic regurgitation or mitral regurgitation?
Things like the width of the narrowest part of the regurgitant jet, vena contracta, the calculated regurgitant volume, how much blood leaks back per beat, the regurgitant fraction, percentage of total stroke volume leaking back, and the effective regurgitant orifice area, EROA, the size of the hole the blood is leaking through.
So specific cutoff numbers for vena contracta, regurgitant volume, fraction, EROA define mild, moderate, severe for AR and MR.
Yes, the guide will provide tables with these quantitative thresholds. It also mentions supportive findings like the size of the color Doppler jet, pressure half-time for AR, signs of flow reversal in other vessels, and importantly, the degree of chamber enlargement, LA and LV size. For MR, it's also key to differentiate primary versus secondary, as grading criteria can differ slightly. Same principles apply to tricuspid regurgitation grading.
So interpreting echo reports requires understanding these key numbers and how they fit together.
Absolutely. And nurses often need to understand the implications of these findings for patient status and treatment planning. The guide might also briefly touch on newer techniques like strain imaging, GLS for subtle LV dysfunction, 3D echo, or contrast echo.
Okay, what about a simple chest x-ray, CXR? Still useful.
Yes, complementary information. It
Yeah.
doesn't show the valves directly, but it reveals cardiac size and silhouette, helping assess chamber enlargement. It's very useful for looking at the pulmonary vasculature signs of congestion or pulmonary hypertension. Sometimes you can see valve calcification, and it helps rule out lung problems as the cause of symptoms.
Good overview tool. Now, stress testing. When is that used in VHD?
Primarily in patients with asymptomatic severe VHD stage C, especially aortic stenosis.
Why stress test someone who feels fine but has severe AS?
Several reasons. To objectively measure their functional capacity, to see if symptoms develop during stress, which would actually bump them into stage D, symptomatic, and indicate need for intervention. To assess the hemodynamic response, for example, does their blood pressure drop with exercise in AS? That's a bad sign. And sometimes to clarify uncertain echo findings, like in moderate MS.
Is it safe to exercise someone with severe AS?
Symptomatic severe AS is generally a contraindication to exercise stress testing, but for asymptomatic severe AS, it can be done carefully in experienced centers.
What types of stress tests?
Can be standard exercise ECG testing,
Yeah.
ETT, or often combined with imaging stress echocardiography, either exercise or using dobutamine drug to simulate exercise. Cardiopulmonary exercise testing, CPS, gives even more detail on functional capacity. Dobutamine stress echo, DSE, is also used in low flow, low gradient AS to see if the valve opens up more with increased flow, pseudosevere, or if the gradient increases significantly, true severe, and to assess contractile reserve.
What findings during stress testing suggest higher risk?
Development of symptoms, obviously, a drop in systolic blood pressure in AS, significant arrhythmias. On stress echo, a large increase in AS gradient, rise in pulmonary artery pressure, worsening MR, or lack of contractile reserve in LFLG-AS.
Okay, so stress testing helps risk stratify those asymptomatic severe patients. What about cardiac catheterization? Is it still done for VHD?
Less often as the first-line diagnostic tool now, because echo is so good and non-invasive.
Right.
But CAT still has important roles.
Such as?
When non-invasive tests, like echo, give conflicting or unclear results, definitely used to assess for coronary artery disease, CAD before valve surgery, especially in older patients or those with risk factors. It allows direct measurement of pressures inside the heart chambers and across the valves, calculating gradients precisely, can calculate valve area using the Gorlin formula, and angiography can visualize and grade regurgitation, though echo is usually preferred for quantification now.
So, more invasive, reserved for specific questions or pre-op assessment.
Pretty much. Involves inserting catheters into arteries, veins, injecting contrast dye, has risks like bleeding, stroke, arrhythmia, kidney injury.
Advanced imaging. Cardiac MRI, CMR, and CT.
Their roles are expanding rapidly. CMR is considered the gold standard for measuring LV and RV volumes, mass, and ejection fraction accurately. Excellent for quantifying regurgitant volumes, too. Can detect myocardial fibrosis, scar tissue, using late gadolinium enhancement, LGE, which has prognostic value. Good for visualizing the aorta, but it's less available, takes longer, more expensive, can't be used with some implants, and not as good for visualizing valve calcification.
And cardiac CT.
Huge role now, especially for planning transcatheter procedures like TAVR, transcatheter aortic valve replacement, or TEER, mitral edge-to-edge repair. CT gives precise measurements of the valve annulus, calcium burden, and vessel access routes. Aortic valve calcium scoring, a VCS, on CT can help confirm severe AS, especially when echo is borderline. Also great for assessing the aorta, prosthetic valve complications like thrombosis or leak, and can evaluate coronary arteries, CTA.
Downsides of CT.
Radiation exposure, contrast eye risks. Not as good as echo for real-time valve motion assessment.
Okay. Lastly, biomarkers like BNP.
Yes, B-type natriuretic peptide, BNP, or its precursor, NT-proBNP. These are hormones released by the heart muscle when it's stretched or under stress. Levels go up in VHD, especially with volume pressure overload or heart failure.
How are they used?
They help with prognosis and risk stratification, particularly in asymptomatic patients. Elevated BNP in someone with asymptomatic severe AS, stage C, even if their EF is normal, suggests higher risk and might be a reasonable factor supporting earlier intervention, especially if surgical risk is low. Also useful for monitoring response to therapy or tracking HF progression.
So putting it all together, history, exam, ECG, echo, maybe stress test, cath, CT, MRI, BNP, gives the full picture.
Exactly. It's about integrating all the data. No single test tells the whole story, and nurses play a key role in providing the clinical context for interpreting these results.
All right, let's move into treatment and management. What are the goals?
Symptom relief, improving quality of life, preventing irreversible heart damage like progressive heart failure, reducing complications like stroke or endocarditis, and ultimately improving survival.
And decisions depend on.
The specific valve, how severe the problem is, whether the patient has symptoms, how well the ventricle is functioning, the patient's overall health and surgical risk, and importantly, the patient's own preferences and goals. Shared decision-making is key.
The guide emphasizes a team approach.
Yes, the multidisciplinary heart valve team is crucial for managing all patients with severe VHD who might need intervention. This includes cardiologists, imaging, interventional HS specialists, cardiac surgeons, anesthesiologists, geriatricians, and specialized valve nurses or coordinators. Complex cases should be referred to specialized valve centers.
Okay, let's talk medical management first. Can meds fix a bad valve?
No, medical therapy cannot cure the structural valve problem itself, but it's vital for managing symptoms, treating associated conditions like heart failure or hypertension, optimizing the patient before an intervention, providing palliation if intervention is impossible, and preventing complications.
What kinds of meds are used? Diuretics?
Definitely. For fluid overload symptoms, dyspnea, edema, loop diuretics like furosemide, sometimes aldosterone antagonists like spironolactone, need to be used cautiously in severe AS, though, as patients can be preload dependent.
Vasodilators, like ACE inhibitors, ARBs, ARNI.
Useful for reducing afterload in chronic severe AR or MR with LV dysfunction or hypertension. Also standard therapy for heart failure. But again, caution in significant AS. Don't want to drop blood pressure too much. Nitroteshydrolizine are alternatives.
Beta blockers.
Standard for heart failure. Good for rate control in AFib, which can be very beneficial in MS by allowing more diastolic filling time. Can help with angina symptoms. Again, used cautiously in severe AS and sometimes avoided in severe acute AR.
Newer heart failure meds. SGLT2 inhibitors.
Yes, drugs like dapagliflozin and empagliflozin are now foundational therapy for HFrEF, reduced EF, and also show benefit in HFpEF, preserved EF, and HFMREF, mildly reduced EF. So increasingly used in VHD patients who also have heart failure.
Digoxin.
Mostly for rate control in AFib if other agents aren't enough, or sometimes for symptom relief in advanced HFrEF, but no mortality benefit shown. Narrow therapeutic window.
Antiarrhythmics.
Like amiodarone, sometimes used for rhythm control in AFib, but rate control is often the primary strategy.
Anticoagulants, this is a big one, especially for nurses.
Absolutely critical. The rules depend on the valve lesion and the rhythm. For AFib, in patients with rheumatic mitral stenosis, the guide says lifelong warfarin, a vitamin K antagonist or VKA, is required, usually targeting an INR of 2-3. DOACs, direct oral anticoagulants, are contraindicated here.
Rheumatic MS plus AFib, warfarin only. Got it. What about AFib and other native valve diseases like AS, MR, AR?
Here, the decision is based on stroke risk, typically using the CHA-2DS2 FASC score. If anticoagulation is indicated, score O2 for men, O3 for women. Either warfarin or DOAC can be used. DOHCs are often preferred now due to convenience and safety profile in this setting.
What about prosthetic valves?
We'll cover that specifically, but short answer, mechanical valves always require lifelong warfarin. Bioprosthetic valves usually don't need long-term anticoagulation, unless there's another reason like AFib.
Any other anticoagulation scenarios?
The guide mentions considering anticoagulation even in sinus rhythm for MS patients if they have a very large left atrium or history of clots.
Antibiotics for rheumatic fever prevention.
Yes, secondary prophylaxis, usually long-term penicillin injections, is crucial for patients with a history of RHD to prevent recurrent attacks. Duration depends on age and severity of heart involvement.
And antibiotics for infective endocarditis prevention.
That's a separate topic, usually based on specific guidelines for high-risk patients undergoing certain dental or surgical procedures. Important, but maybe slightly beyond this VHD focus.
Statins. We said they don't stop AS progression.
Right. But they should still be used according to standard guidelines for preventing atherosclerotic cardiovascular disease, ACVD,
Yeah.
if the patient has other risk factors. They just don't target the valve calcification itself.
Okay, so medical therapy manages symptoms and associated issues. What about fixing the valve? Surgical intervention, repair or replace?
That's a key decision. Valve repair is generally preferred over replacement whenever feasible, especially for the mitral and tricuspid valves.
Why is repair better?
Better long-term durability in many cases, especially degenerative MR repair, avoids the need for lifelong anticoagulation with mechanical valves and avoids the risks associated with prosthetic valves themselves, thrombosis, endocarditis, SVD.
So for mitral valve disease,
Repair is the gold standard for primary degenerative MR in experienced centers. For severe rheumatic MS or MR, or severe secondary MR, or if repair fails or isn't possible, then replacement is needed. Surgical opening of fused mitral leaflets, commissurotomy, is less common now. Balloon procedures are preferred for MS if suitable.
aortic valve.
Replacement, either surgical SAVR or transcatheter TVR, is the standard for severe AS or AR. Aortic valve repair is done sometimes, but is much less common and more technically demanding than mitral repair.
Tricuspid valve.
Repair is preferred for severe TR, often done at the same time as left-sided valve surgery. Replacement if the valve is too damaged or repair fails.
Timing of surgery is critical, right? Linked to the stages.
Absolutely. Based on the AHACC staging, generally indicated for severe symptomatic disease, stage D, also indicated for severe asymptomatic disease, stage C, if there are signs of LV decompensation, C2 falling EF, significant LV dilation, or other high-risk features, very severe VHD, abnormal stress test, very high BNP. Specific criteria exist for AS, AR, MS, TR. The guide likely details these indications. Also consider surgery if the patient needs cardiac surgery for another reason, like bypass, and has moderate or severe VHD concurrently.
And surgery always carries risks.
Of course, standard cardiac surgery risks: bleeding, infection, stroke, arrhythmia, death, plus risks specific to valve surgery, heart block requiring pacemaker, prosthetic valve issues. Risk scores like the STS score help estimate individual patient risks.
If replacement is needed, big choice. Mechanical versus bioprosthetic valve.
Huge decision. Requires shared decision-making with the patient.
Mechanical valves. Pros and cons.
Pro. Very durable, likely to last a lifetime. Con. Require lifelong anticoagulation with warfarin, VKA, with strict INR targets depending on valve type and position and patient risk factors. DOACs are absolutely contraindicated, can cause a small audible clicking sound, higher risk of valve thrombosis or bleeding complications due to warfarin. Aspirin is often recommended in addition to warfarin.
Biprosthetic valves, tissue valves, porcine, bovine pericardium.
Pro. Generally don't require long-term anticoagulation, though short-term post-op anticoagulation is sometimes used, and lifelong low-dose aspirin is often reasonable. No clicking sound. Lower risk of thrombosis and major bleeding compared to mechanical valves plus warfarin, con. Less durable, prone to structural valve deterioration, SVD over time, meaning they may need re-replacement eventually. SVD risk is higher in younger patients.
So how do you choose?
Guidelines usually recommend based on patient age, life expectancy, bleeding risk, patient preference regarding anticoagulation, lifestyle impact, adherence ability, and whether the patient needs anticoagulation for another reason anyway, like AFib. Generally, younger patients, 50, 65, depending on guidelines, might lean towards mechanical for durability, while older patients, 65, 70, often lean towards bioprosthetic to avoid warfarin, but it's very individualized.
Okay, surgery is one option. What about less invasive approaches, transcatheter valve interventions?
This field has exploded. Minimally invasive options delivered via catheters, usually through leg arteries, veins, or small chest incisions.
TAVR-TAV is the big one for aortic stenosis.
Transcatheter aortic valve replacement implantation. A biprosthetic valve crimped onto a balloon or self-expanding frame is delivered via catheter and deployed inside the diseased native aortic valve.
Who gets TDR?
Initially for patients who are too high risk or inoperable for traditional open heart surgery, SAVR. But indications have rapidly expanded now to include intermediate risk and even low-risk patients with symptomatic severe AS, especially older patients or those with favorable anatomy. Current guidelines give recommendations based on surgical risk, age, and life expectancy. It's now a mainstream treatment.
How do outcomes compare to surgery?
Generally similar survival in many groups, often with faster recovery and lower procedural morbidity, like bleeding, kidney injury, new AFib. TAVR might have slightly higher rates of paravalvular leak, PVL, around the valve, and need for permanent pacemakers compared to SAVR, though these are improving.
Oh.
Currently, TAVR isn't typically used for pure severe AR without AS.
What about the mitral valve? Transcatheter options there.
Yes, primarily transcatheter mitral valve edge-to-edge repair, or TEER, using devices like the mitral clip.
How does TEER work?
A clip is delivered via catheter, usually through the femoral vein, crossing to the left atrium, and used to grasp the middle portions of the anterior and posterior mitral leaflets together, creating a double orifice valve and reducing the regurgitant opening.
Who is TEER for?
Main indications are for patients with severe symptomatic primary Mendiar, degenerative, who are at high surgical risk and have suitable valve anatomy. Also, for selected patients with severe symptomatic secondary MR who remain symptomatic despite optimal medical therapy for heart failure, again with suitable anatomy and meeting specific echo criteria, like those used in the COAP trial.
Outcomes of TEER.
It effectively reduces MENDA-R severity, improves symptoms, and reduces heart failure hospitalizations, particularly in the secondary MR group studied in COAPT. It's less effective at eliminating MR than surgical repair replacement, but is much lower risk. Complications can include residual MR, clip detachment, or rarely causing mitral stenosis.
Any transcatheter options for mitral stenosis?
Yes. Percutaneous balloon mitral commissurotomy, PBMC, also called PBMV, a balloon catheter is inflated across the stenonic-rheumatic mitral valve to split the fused commissures.
Who gets PBMC?
It's the treatment of choice for suitable patients with symptomatic severe rheumatic MS, provided the valve morphology, leaflet mobility calcification, subvalvular thickening, is favorable on echo. Not for calcific degenerative MS.
And for mitral replacement via catheter, TMVR.
Transcatheter mitral valve replacement is still an emerging field, much more complex than TAVR due to the mitral anatomy. Several devices are in clinical trials, but none are widely approved yet for native valves. Challenges include anchoring the valve securely, risk of obstructing outflow from the LV, paravalvular leak, and thrombosis. Transcatheter valve TMVR, placing a TAVR valve inside a failing surgical mitral bioprosthesis, is becoming more common for high-risk patients.
And the tricuspid valve.
Transcatheter tricuspid valve interventions, both repair and replacement, are also rapidly evolving. Several devices are being studied for treating severe TR in patients, often considered too high risk for surgery. Promising area, but still mostly investigational.
So lots of movement in the transcatheter space, offering less invasive options for many.
Definitely expanding treatment possibilities, especially for older or sicker patients. Heart team discussion is crucial for choosing the right approach.
What about when prosthetic valves fail? Management of prosthetic valve dysfunction.
Always maintain a high index of suspicion if a patient with a valve replacement develops new symptoms. Diagnosis often starts with TTE, but frequently requires TE, CT, or fluoroscopy for confirmation.
If a mechanical valve gets a clot, thrombosis.
That's a medical emergency.
Yeah.
Treatment depends on clot size, and patient stability options are urgent surgery to remove the clot to replace the valve, or fibrinolysis, clot-busting drug. Anticoagulation needs to be optimized.
Clots on bioprosthetic valves.
Also occurs, usually treated first with therapeutic anticoagulation, warfarin or sometimes DOACs.
Structural valve deterioration, SVD of a bioprosthetic valve.
Requires reintervention, either redo open heart surgery or increasingly a transcatheter valve procedure, placing a new transcatheter valve inside the failing surgical valve, especially for high-risk patients.
Paravalvular leak, PVL, leakage around the valve sewing ring.
If it's causing significant symptoms like heart failure or hemolysis, red blood cell destruction, it needs closure. It can be done surgically or, increasingly, via transcatheter closure devices.
Prosthetic valve endocarditis, PVE, infection.
Very serious complication. Requires prolonged high-dose antibiotics. Often needs surgery to remove the infected valve and surrounding tissue and replace it, especially if there's valve dysfunction, abscess, or persistent infection.
So, managing VHD is complex, evolving with medical, surgical, and transcatheter options. Heart team and shared decision making are vital.
Absolutely, it's highly individualized care.
Okay, let's bring it home for the nurse. The nursing navigator role in VHD care. Comprehensive assessment is job one.
Combining subjective data, what the patient tells you, and objective data, what you find.
Patient history. Chief complaint, detailed symptom analysis, PQRST for pain, assessing dyspnea, orthopnea, PMD, past medical history, crucial for RHD, i.e. congenital defects, medication review, especially anticoagulants, functional status like NYHA class, psychosocial factors, lifestyle, diet, activity, smoking.
Physical exam. Vital signs, BP in both arms, thorough cardiovascular exam inspection, GVD edema, palpation, pulses, PMI, thrills, heaves, and meticulous auscultation. Identifying murmurs, extra sounds, report any new or changed findings immediately. Don't forget respiratory assessment, lung sounds, SpO2, fluid balance assessment, INO, daily weights, edema tracking, neurological checks, watching for stroke signs, and pain assessment.
Diagnostic monitoring. Interpreting ECGs, telemetry strips, 12 leads use that systematic approach. Reviewing lab results, electrolytes, renal function, CBC, coagulation studies like INR, BNP levels, and monitoring hemodynamic parameters if the patient has invasive lines, like arterial lines, central lines.
Okay, assessment done, key nursing interventions. What does the guide highlight?
Optimizing cardiac output and perfusion. Giving meds as ordered. Diuretics, vasodilators, beta blockers, inotropes if needed, and monitoring their effects and side effects closely. Providing oxygen therapy, maintaining hemodynamic stability, positioning for comfort and optimal breathing, elevating head of bed, balancing activity and rest.
Managing fluid balance, administering diuretics, tracking response, urine output, weight changes, monitoring electrolytes, especially potassium, enforcing fluid and sodium restrictions if ordered, meticulous intake and output recording, daily weights are crucial.
Promoting gas exchange, frequent respiratory assessment, monitoring oxygen saturation, SpO2, proper positioning, administering oxygen, encouraging deep breathing and coughing exercises.
Managing activity and tolerance, assessing baseline function, planning for gradual increase in activity as tolerated, teaching energy conservation techniques, scheduling rest periods, referring to cardiac rehabilitation programs.
Pain management, assessing pain thoroughly, administering analgesics appropriately, using non-pharmacological comfort measures.
Reducing anxiety, providing a calm environment, offering emotional support, giving clear and simple explanations about procedures and care, teaching relaxation techniques, administering anti-anxiety meds if ordered, involving social work or spiritual care as needed.
Preventing complications. This is huge. Strict hand hygiene and aseptic technique to prevent infection, implementing bleeding precautions for anticoagulated patients, monitoring labs, applying pressure to sites, preventing thromboembolism, encouraging mobility, using SCDs, administering anticoagulants, monitoring for DVTPE signs, monitoring ECG continuously for arrhythmias, and responding per protocol, ensuring emergency equipment is ready.
What about post-op care after valve surgery or TAVI-TIR?
That requires intensive monitoring. Frequent vital signs, hemodynamic monitoring, continuous ECG, respiratory status checks, neurological assessments, monitoring urine output, chest tube drainage, incision sites, aggressive pain management, vigilance for complications like bleeding tamponade, stroke, heart block, need for pacing, kidney injury, infection, prosthetic valve dysfunction, PVL, gradual mobilization, weaning from ventilator support if applicable, and extensive patient and family education before discharge covering medications, activity restrictions, dietary changes, wound care, signs, symptoms to report, and follow-up appointments. The guide likely lists common nursing diagnoses related to VHD.
Yes, things like decreased cardiac output, activity intolerance, excess fluid volume, impaired gas exchange, anxiety, fear, deficient knowledge, risk for bleeding, risk for infection, and associated interventions for each.
And evaluation. Closing the loop.
Constantly evaluating if the interventions are working. Are hemodynamics stable? Is fluid balance improving? Are symptoms reduced? Can the patient tolerate more activity? Are complications prevented? Does the patient understand their care? Is anxiety lessened? If outcomes aren't met, the nurse needs to reassess and adjust the plan. Critical thinking is key.
The guide also touches on potential complications of VHD itself. Factors influencing prognosis like severity, symptoms, EF, comorbidities, timeliness of intervention, and managing those complications. Nurses play a vital role in monitoring for deterioration and reinforcing adherence.
Anticipatory guidance, early recognition, advocating for the patient. all part of the nursing role.
And finally, patient education and health promotion. The guide emphasizes this as a cornerstone, empowering patients through knowledge.
Huge part of nursing care in VHD, helping patients understand their condition, medications, lifestyle changes, warning signs. It makes a massive difference in outcomes and quality of life.
Absolutely. So that covers a huge amount of ground from the guide. We've gone from basic valve function and dysfunction through the global picture, risk factors, detailed pathophysiology, compensatory mechanisms, the different valve lesions.
The staging system, clinical manifestations, physical exam pearls, all the diagnostic tests from ECG and echo to cath and CT, biomarkers.
Then the management strategies, medical, surgical repair versus replacement, mechanical versus tissue valves, the expanding world of transcatheter interventions like TAVR and TEER, managing prosthetic valve problems.
And finally, zeroing in on the comprehensive nursing role assessment, interventions, monitoring for complications, post-op care, and patient education.
We've really unpacked the critical information from the Valvular Heart Disease Nursing Guide, focusing on what you need for clinical practice and those exams. Hopefully, you're feeling more confident navigating this complex topic.
It's a lot, but breaking it down systematically helps make sense of it all.
Definitely. So here's a final thought to leave you with. Considering the rise in age-related VHD and the rapid advancements in less invasive transcatheter therapies, how do you see the nurse's role evolving even further in the care of VHD patients in the coming years? Something to ponder.
Great question. More specialized roles, perhaps. Greater emphasis on long-term surveillance and managing patients post-transcatheter procedures. Lots to think about.
Indeed. We hope this deep dive was valuable. Feel free to revisit any sections or explore areas that sparked your interest further. Thanks for joining us.
Keep learning, keep questioning. You've got this.